Well, good morning, everyone. Welcome to, by my count anyway, day 36 of living indoors, hoping for the best, truly exploring the edges of the Netflix universe to find out what's there for our mutual amusement. Let me thank our good friends at Ameriflex for sponsoring today's event. Let me also thank Dan Perrin, Employer Coalition for Direct Care and Principal Representative of the ABA's Health Savings Account Council. We're joined by a veritable who's who of the direct primary care world. But first, we thought we would introduce a genuine friend of the industry of healthcare in general, and one of the very few active physicians in the United States Congress, and one of, I believe, only two in the United States Senate, our good friend Bill Cassidy. Dr. Bill Cassidy, joining us from Baton Rouge. I note for the record that this is called a necktie. This is what we used to wear when we went to see United States senators. I thought I would keep up tradition. Call me old school, but I thought that's where we would go first. Those of you that know Bill know of his literally unrelenting support for health savings accounts, for consumer-directed healthcare, for direct primary care. But his interest also in making sure that the United States finds its way back to the largest economy the world's ever known, and the most ambitious economy the world's ever known. And I understand that he has some interesting ideas along those lines. But first, let's say this. This is a new way of communicating for everybody. It has obvious limitations. You can't just turn and ask a question. We'll try to moderate the questions as we go through our doctor panelists over the course of the next hour. Everyone will be muted until we do that. We will have a very robust attempt to get to your questions either now, or we'll answer them in the future by email if needed. Now, with all of that said, I can see that he's assumed the position, as they say, which is he's got his home office ready for communication. And so good morning, Bill. Senator, thank you very much for joining all of us. There's a huge number of people on the call, not just because this is the only way to communicate, but because there's a huge number of people that are very interested to hear in what you might have to say, especially with respect to how deliberations are going in Congress, how you're working with your colleagues, but mostly your ideas around immunology and how you expect the future to unfold. And so good morning, sir. Thank you for joining us all.
Hey, good morning, Kevin. Of course, I'm assuming that you have your PJs on, from waist down. So even though you have the tie, it's, kind of a sham. You know what I'm saying? At least after
very network
Dr. Pinckney sleeps in his scrubs, and so he just could roll out of bed looking like he's ready to go.
That's right.
I'm there with you, man. Listen, I thought I would just briefly go over the state of play, both in terms of the CARES Act. There's a lot of physicians who are basically small businesses, then go through the DPC provisions, maybe a call to action, and then what can we as physicians advocate for as an off-ramp to this economic shutdown. And then I'll try and go through quickly. Everybody on this call is well versed with what I'm speaking of. So, but I'll, like to leave a lot of time for questions. First, state of play. CARES Act implementation, there's $100 billion in there for healthcare providers. $30 billion has gone out. Additional grants are imminent. Specifically, we ask, will you be giving to independent physician practices, not just those associated with hospitals? They said absolutely. So there will be money going directly to physicians, physician practices from that $100 billion. The president has said, and the HHS has said, if someone comes to see you for COVID-19, that they are uninsured, you will be reimbursed as if they were insured. So just to say that up the outset. A lot of those businesses, for example, are not, think the dermatologist. The dermatologist in most communities is not seeing COVID-19 patients. They're jogging, doing their garden, but also wondering how they can keep their payroll. The program works, the payroll protection program, as you all know, allows people to borrow up to 2.5 times average monthly payroll, and the degree they use money for payroll, utilities, rent, or mortgage interest, it is forgiven as a grant. It does not have to be paid back as a loan. Now, the program has been so popular that it's oversubscribed, it has run out of money. We're negotiating now to add 250 billion more to the small business payroll protection plan. Pelosi and Schumer are holding out. They want more money for fill in the blank. McConnell's position has been, if you want more money for hospitals, but we still have 70 billion we've not yet spent, let's spend our 70 billion. I promise you we'll come back. Really, Pelosi and Schumer, I think, are using the excuse more money for hospitals to actually get more money for things like the Kennedy Center. That's the politics of it now. I'm hoping the pressure is building on them to give way so that we can start getting money out to small businesses, not just physician dental practices, but also the hotel, the restaurant, others that are trying to keep, kind of the payroll together so when all this is over, they can get back into action. You can call your congresswoman, your congressman, though, hopefully ask them to put pressure on Pelosi. Phase 4 will have more money for healthcare, but it'll have a lot of money to prime the pump to get the economy going again. All of us are dependent upon people having intact businesses, benefits to pay for services, et cetera. So we do need to get financial health as well as physical health on its way to recovery. What am I working on? Let me talk about the direct primary care, by the way. We had a bill, our direct primary care bill that we'd introduced with Doug Jones was included in the original finance release package. I'm told Senator Wyden struck it, the Democratic senator from Oregon, during negotiations. Chairman Grassley from Iowa, he's the chair of finance. Wyden is the ranking Democrat. Grassley pushed for it, pointed out, middle-class Americans, 60% of health savings account are held by Americans earning less than $100,000 per year in employer high deductible health plans. Recall our direct primary care would allow HSAs to pay for that monthly contract you have in DPC. Wyden, you can't move his staff beyond the idea that somehow this is going to be a big boon for concierge medicine. They hate the concept of concierge medicine. As much as we point out that the policy capped the amount of money that would be allowed for a monthly DPC fee, 150 for an individual, 300 for a family, and that would prevent somebody from paying a concierge subscription from their HSA, they cannot comprehend that. So everybody in Oregon, call up Wyden's office, make an appointment with their staffer, let them know that's not true. If you're in Washington State, get Maria Cantwell to help us. Boeing weighed in heavily. At one point, Maria was helping us, then she backed off. We need her help to talk to Wyden to get Wyden on board, because Wyden has the ability to kill this despite the soundness of the policy. And it's just become an article of faith for these people. So you need to move them beyond the article of faith, allow them to understand facts, not some prejudice. Now let me go back to what I'm working on. We need to know who's immune for several reasons. If you're going to talk about contact tracing, we have to know who's infected. And if somebody is infected and we want to trace down their contacts, if we know that 5 of the 6 people they are in contact with are already immune, we don't have to trace down those contacts. We only go after the one person who's not immune. How do we know someone's immune? There has to be widespread deployment of testing. We can assume if somebody tested positive for RNA and 14 or 28 days later they've cleared the infection, then that they are going to develop antibodies, because that's what you do when you've been exposed to a virus. You could also check the antibody itself by saliva or by blood. There are tests being deployed. IgM goes up quickly, followed by IgG. It appears to be protective. We don't know this yet for sure, but it appears to be. If we're able to document immunity, and I'm proposing we use the same immunization registries we use for our children being vaccinated to document who's been immune from actual infection, we can begin to reopen the economy with some sort of risk stratification. I call it the if, and, then, but strategy. If you have an antibody and you're at otherwise low risk, then you can go out into society with a public facing job with less concern about being infected. Versus if I don't have antibody and I have diabetes, obesity, and hypertension, then I know that I'm at high risk and I may want to stay at home until all this passes wearing neckties on Zoom calls.
You're welcome.
But you can have always some sort of kind of algorithm based upon the person. If I have antibodies and I have diabetes and high blood pressure, then I may be protected, but I'm not sure. And so I'll probably still wear protective equipment until we have more facts on the ground. So it allows that sort of decision analysis that medicine is used to. But the backbone of it is knowing who's immune, who's not immune. And I do think the logical place to put that data is in the immunity registries we already use for immunization, which have a robust set of privacy laws to protect that information, and that we've been using for 25 years so that we know that they work. Kevin, let me stop and take whatever questions or turn it over to somebody else.
Thank you, Senator. Your plan seems reasonable and logical, which is to say adjectives that don't generally apply to debate in Washington, D.C. Can you provide us some level of discussion with your very sober professional view of how the world turns back on versus some of the politics you just described, wherein there are those who will not let a crisis go to waste and pursue whatever agenda they find most attractive at the time? Is this the knuckleball that the country is trying to get by, at least from your chair in the Senate?
I think that I think this is the special role of the healthcare community. We know immunity is important. We know right now that COVID-19 is a reportable disease, meaning just like syphilis, we know who has it. We know their name, their address, their phone number. At some point, when Dr. Redfield, head of CDC, talks about contact tracing, we know just like syphilis, where we track down the contact of every person with syphilis, he envisions being able to track down the contact of everybody who is reported with the disease. That therefore means that we are keeping track of who's infected, who's not. We know that we have these immunity registries in which we follow people for immunization. We know there's privacy laws around them. We have an alternative. Either we keep writing checks from the federal government as we watch business after business go bankrupt, or we employ the public health mechanisms that we have with robust privacy laws that we know work in order to find out who's immune, who's not, to reopen the economy as much as possible until we get a vaccine. I think we need to advocate for the latter and not just sit back passively watching people go bankrupt and our country go deeply in debt. But that's my perspective. We have a letter that will be advocating this approach, signed by a bipartisan group of, I think, 11 or 12 senators that will go out today. We need this approach, and we need people to understand it and people to advocate for it. And frankly, you guys on the call would be great advocates.
I see a lot of nodding heads among our doctors. I would imagine that is a strategy that will gain quick support. We've been anecdotally calling it the acceptable risk strategy, which is to say, you're not prepared to just sit in your chair and wait so that no lives are at risk, because we're all at risk all the time from texting and driving and things like that. Do you think there is at least some element of relativism among the people signing that letter, that they believe exactly as I described, which is life is full of risk. We have found a way to manage those risks. Privacy concerns have already been managed because we have these immunity registries. And so therefore it's time to go. Is that the level of maturity that you think you're seeing in the Senate at this point?
Among those signees, there are some who do not yet comprehend what the alternative is. The alternative is to hunker down until we get a vaccine, which is 12 to 18 months from now. They think, no, we can go back to where we were 3 months ago without wearing protective equipment, without worried about being immune, without having some sort of way to track those who are super spreaders. That's absurd. But we have the advantage of having an education which acquaints us with the concept of a super spreader, of the importance of immunity, and the importance of being able to track those who are or are not immune and protect those who are not immune. We need to use the advantage of our education to educate others.
Senator, I appreciate that. To Dr. Garrett Price first, if he could just describe for us, in his view, some of the value proposition that direct primary care brings versus some of the fee-for-service models and hospital models that are out there. And for those of you who tuned into us, Dr. Garrett Price is probably heard but not seen, I think, is our technological limitation right now. But are you there, Doctor?
I am here. So thank you, Kevin. And so I think that's an excellent question. And, you know, the way to really look at it and frame it is that, you know, you kind of look at what I call current state of primary care and that fee-for-service model where patients are on average taking 18 and a half days to be able to get in and see a primary care doctor. And when they do get in, that's about a 15-minute visit. Those are national metrics. There's a lack of overall integration and collaboration between systems. You also look at the amount of technology built into that particular model, which is not impressive at all, or there's a lack of technology integration, or it's poorly adopted amongst the system, amongst physicians.
I think that's fascinating, and I know that's a sentiment that the other physicians share as well. And I wanted to turn to Dr. Blanchard. I know you're up in Troy, Michigan. I know that's been a hot spot. Your governor has put her foot into some of the more interesting political discussions around staying at home and when to turn the economy back on and so on. But your expertise, and for the audience, it's my privilege to be able to have dinner with the doctor prior to the great lockdown. Hard to believe that was 36 days ago. But here we sit from your chair up in Troy, Dr. Blanchard. What kinds of dynamics do you see, and how important do you think it's been to have employers have DPC services for their employees and to make it, of course, HSA eligible?
Thanks, Kevin, and it's good to be here with you today. We are one of the hardest hit states in the country. I think we're in the top 5 in terms of number of cases, but just to give everybody an idea of what it's like here in Michigan, our hospitalization rate is 123% higher than the hospitalization rates per 100,000 people in New York. So our hospitals were barraged early on. Fortunately, we weren't overrun. Our hospitals were able to meet the demand. But I want to go back a little bit with the history of our company, Salta Direct Primary Care in Michigan. We started in 2001, and our goal was to bring this advanced primary care delivery model to every man, woman, and child in the country. And we had moderate growth in growing direct primary care in the individual market where people were paying a monthly fee for it. We grew until 2009, but with the recession, it became clear to us that we'd probably only be able to reach 12% of the, maybe 15% of the marketplace with people paying individually for direct primary care. So it became clear to us at that point that we needed to begin contracting directly with companies. And so for all the companies that are on the call that has companies or is looking at this from a company benefit standpoint, it was really needed in order for us to go and scale this to larger numbers of people for companies to participate in paying for the direct primary care benefit. And that's why this HSA is so important. We've got to get the Primary Care Enhancement Act passed because it would allow individuals to use their HSA, and we could then go above this 12-15% of people paying out of pocket. They'll have a better ability to access direct primary care, and companies will have an easier time providing it as a benefit if our bill passes, because if they have an HSA, they can combine their qualified plan with a direct primary care benefit, which would then, really extend the direct primary care model to many, many more people in the country. This is critically important. I want everybody to understand on the phone what happened here in Michigan. We put a task force together for our company. We have now 8,000 patients, 6 offices. 88% of them are in our practice because of a corporate benefit. that's being offered. 12% are in the individual market. But we planned for a pivot to virtual care in handling the COVID virus, knowing what was coming. What we didn't plan for, which was really a surprise for us, was the primary care private offices in the community who are already at risk because of the poor reimbursement and all the regulatory issues around billing for primary care. We're already at risk. And then when the shutdown happened, they had to close their doors. They couldn't make enough money to pay their employees. They had to lay their employees off. So we had a sudden drop in the primary care delivery system throughout Southeast Michigan. And they pivoted to virtual care, but they could only provide a little bit of virtual care because it's just one person, trying to do that for their practice. So overnight, we became one of the only primary care offices that were fully functional, able to see patients in the office because people still have chest pain, abdominal pain, they still didn't need to be triaged. But most importantly, when you have the COVID hit as hard as it has been here in Michigan, the primary care front line is critically important to triage those patients. We're taking care of lots and lots of COVID patients at home who are really very, very sick. That's really important to keep them out of the hospital, out of the emergency room, to reserve that resource for people that are needing it. And so just at a time when we need a primary care, there's more primary care providers providing care for COVID patients today than in the hospital. But at the same time, we have a lot who have had to close their doors. So this has to be something that's really brought to the forefront, and passing our bill would allow all of that regulatory burden to go away, allow doctors to get paid in this comprehensive way for comprehensive primary care, and take care of people in the way that they should be taken care of.
Well, obviously, I couldn't agree more. One of the insults to intelligence is that if you have a health savings account, which is there to spend on medical services because of your delivery model, the IRS has taken its own position. It says, well, you couldn't possibly buy medical care from these gentlemen. They're in a direct primary care relationship. You can't pay for that under the deductible. And the employer is, because they're doing the providing here, which is the most important part, well, that's other coverage. And I know that always strikes Dr. Cassidy as ridiculous, which is why he's so ardent in favor of this bill. And there was a time when it struck Senator Cantwell as ridiculous as well.
Concierge medicine is when you charge a retainer fee and bill insurance. Direct primary care, there's no insurance whatsoever. We charge a monthly membership fee, a capitation, that provides unlimited visits, no copays, 24-hour access to your doctor, and unlimited urgent care. So with our insurance-based colleagues, they really struggled going to virtual care, and they're fee for service. So when their patients aren't coming in to see them, they can't get reimbursed, and they're shutting their doors.
Primary care is one of the models where we embrace technology early on. We've given better access to patients through technology, most of us for years. I mean, I've been doing it for nearly 20 years. And as early as we had something we could use for telehealth, we were doing that. And it sort of comes with the territory. I think Dr. Pinckney said correctly that it's a little bit easier for us to make that transition than our fee-for-service colleagues. We did it, I think ours was March 15th, where we essentially sent out something to all the patients and said, look, we're going to a virtual only mode at this point for your protection. We didn't want our 80-year-old patients with chronic disease in the office sitting next to somebody else. But one of the things that makes it different than just telehealth in general is that DPC doctors know their patients really well. They have that established relationship. Generally, they've spent more time face-to-face with those patients. And so you can still do fairly comprehensive care as a DPC physician, even when you're doing it virtually, because that's not necessarily new to our model.
Yeah, I just wanted to comment on, just to give everybody an idea, we had a 160% increase in patient encounters in March compared to the previous month. So that's compared to, in the traditional setting, a lot of primary care doctors, went down to half or zero encounters. And I think what's really still has to be we'll see what happens is that I believe that there's going to be a lot of older doctors who were in primary care who are on the verge of closing their office already. They're just not going to reopen. I think this whole thing is going to lead to even more of a primary care shortage in a lot of communities. I have colleagues who said, John, I had to let go of my patients. I'm 62 years old. I wanted to practice for another 10 years, but I'm done. I'm not going to reopen,
Right.
And I think that's something that we're going to see. The other thing I wanted to expand on is that this whole triage concept, when we have a COVID patient, they're getting a phone call every 2 days. And then if they get short of breath, they're getting a call every day to talk, and we're bringing them in to check their oxygen levels, because what happens is people are crashing in the second week, and it can happen really fast. So a lot of doctors who don't have the ability to bring them into the office to assess their severity and check their pulse oximetry, their oxygen level in their blood, they're trying to manage them over the phone, and these people are getting really sick. And I think we're going to hear stories of people actually passing away at home because they didn't have access to be evaluated in person. I've had a number of patients that I've sent to the emergency room because I thought they were sick enough for hospitalization. They've been sent home. So I think that's a big problem.
I had a question about that, and Dr. Blanchard, you mentioned some of this, which was oxygen levels are the key. Making sure you understand them so that you can know when to move from home to hospital or home to a higher level of care is key. It seems to be going the other way in your state, in Michigan. Anecdotally, we understand the governor may be making some choices here. Is it the hospitals that are sending some of these folks home when they shouldn't be going home? How is this metric playing out? And I guess the heart of that question is there some level of politicization here where the governor's actions are dictating that the patients be sent home instead of kept in the hospital? Do you have any insight on that, or not really?
No, I don't think it has to do with the governor. In fact, I think the governor has done a really good job at one of the reasons why our fatality rate isn't higher is because of the quarantine that was in place. We have a lot of cases, but it would have been a lot more cases if we didn't go into quarantine early. It was really by necessity that, we just simply didn't have enough beds, and so I've been managing people with, unilateral pneumonia, pneumonia on one side, really sick patients at home, but it's been by necessity because there hasn't been enough beds to get them, into a bed. And the reality is that from the Italy experience, it's better for us to be managing these patients at home if we can do it effectively, because you don't want them, going into the emergency rooms where I think I have COVID and then you don't, you go there and you're exposed to someone who does, and then you go home and you infect somebody else at home. It really can help mitigate the problem if we had or have a foundation of primary care that could safely and adequately take care of these people at home. The problem is that our primary care system as it exists isn't built to do that. And that's why we're, in the state that we're in.
I've had the privilege of eating with two of you, which is to say, I know that you've worn out your shoes and your handshakes trying to convince people of the dynamics Dr. Forrest just describes. But I do want to focus on something that Dr. Cassidy brought up that the audience should be well aware of, and that is this bill has been around a while. You can obviously understand from the discussion among the physicians how important it is, not just generally, but to a workforce. And you now understand the role of DPC practices in COVID-19. One person put an end to this in our last discussion, and that was Ranking Member Wyden.
Yeah, I've got just one more point. I think the fact that I can use my HSA account to pay for these designer glasses and not to enroll in a DPC practice is ridiculous, and we really have to band together and facilitate change and get this HSA piece put into the next bill.
Couldn't agree more. Dr. Blanchard.
Yeah, Kevin, healthcare costs are the defining issue of our day. We're spending 20% of the gross domestic product on healthcare. It's challenging the financial health of companies, of individual households. It's challenging our entire country. Every dollar more that we're spending on healthcare is less for infrastructure, education, other things that we need to spend our money on. Direct primary care has been shown to lower overall healthcare costs by 20 to 40%. Government and insurance companies need to get out of the way and pass this act so that primary care doctors can go to work and take care of Americans.
Well, I want you to be able to do that. The president has just posted something called Liberate Michigan. And so I expect that there will be a lot of light on not just what you're doing there, but what you're going to be doing. Well, very good. Physicians, gentlemen, you're at the front line. Thank you for your service. Thank you for doing what you do. Thank you for being advocates. And don't get worn down by this. Make sure you're in there. And for all of you listening, make sure you participate. These 4 people are trying to change the world. Help them. That's what we really need. Thank you all for joining. Have a wonderful weekend. We'll talk to you again very shortly.